We're here for the next 45 minutes to talk about something very important to pretty much everybody in this country, something I write about most days of the week, the future of the NHS. The NHS in a wee bit of trouble, as you might have noticed. Bad headlines, not just with hacking, but with problems with staffing, money, all the rest of it. You don't need me to go over the litany of them. The three expert panelists we got here will touch on some of that, I'm sure. There was also a big growing debate about whether or not our system of healthcare was sustainable long before the vote on the 23rd of June last year came along to complicate things further. So we're going to talk a lot about that and the impact of that on the NHS. I'm going to briefly introduce our really terrific panel, full of knowledge, ideas, passion, experience, frontline experience, intellectual experience, knowledge of inquiries, reports, commissions, everything you want on both domestic health policy and international European health policy. Professor Martin McKee, to my right, is a professor at the London School of Hygiene and Tropical Medicine. Martin, you're also still the chair of the European Public Health Doctors Association.
Past.
Recent past president.
Public Health Association.
Rachel Clarke, to my left, is, I was going to say, a junior doctor. She's a junior doctor, she's a blogger, she's a writer, she's an NHS campaigner. She's written a book that's coming out in July that I've had a sneak preview of that's not half bad. And Professor Anita Charlesworth has done many jobs in Whitehall and in and around the NHS, and is currently the Director of Finance and Research at the Health Foundation, a very robust and very independent think tank. So we are going to kick off first of all, I'm going to moderate a few questions, a bit of a discussion with the panel, and then, as we said, about 10:15, we'll have as many questions as we can fit in to the relevant speakers. The obvious question we introduced about trade deals there in the introduction. Martin and Anita in particular, what's the future, what future benefits or indeed perils might there be for the NHS in any trade deal post-Brexit?
Yeah, well, obviously we don't know. I mean, we had a white paper on Brexit, and the government struggled to fill the pages to the extent that they left five of them blank and put large blue rectangles on another 5. So we really have no idea, but it is pretty obvious that if we go to any new free trade agreement, then as we negotiate, particularly with the United States, health and education are the two areas that they will go for. And what's paradoxical about all of this is that a number of people on the left actually voted for Brexit because they were concerned about the transatlantic trade and investment partnership. Now, there's a really important issue here because our relationships with the EU, people were concerned about competition law. I've written critically about EU competition law, but EU competition law is overseen by the courts and the European Court of Justice, which bases its decisions on the treaties, which have in them a high level of protection of human health. So health is absolutely central. The European Court of Justice has always put a priority on health in its decisions, and you can see that in all of its rulings. It meets in public. It uses evidence. We have all of those things, and if we don't have that, we move to an investor-state dispute settlement process in secret with negotiators nominated by the two parties, and that's where you get the problems. And what's really interesting is that whenever the TTIP was actually on the agenda, the European Union, because the European Union does things publicly, it does things openly, even it does dinner parties in Downing Street openly, but whenever it does things openly, it made it clear that its negotiating process with the United States was that there would be an investor court system that would be transparent and would be open, and that was one of the reasons why the negotiations broke down. So yeah, of course, that's going to be what the United States wants. Why wouldn't it be? The health insurance companies, the providers in the US are themselves struggling. They need more markets. The difficulty, of course, for them, and this is the problem, is that you can make money from private healthcare in the US when you're spending 17.7% of GDP on it. You cannot make those large sums of money in the UK when we're spending, and there's some debate about how you calculate the figures, but certainly an awful lot less. So how profitable it will be very difficult. The only way they can possibly make money is by what we call cream skimming. They'll go for the lucrative bits, and anybody with mental health, anybody with complex chronic diseases, anybody who's old, forget about it. And even in the United States, that's the case. You know, the private insurance system in the United States only works because they've taken all the people who are old, over 65, put them into federally funded Medicare, anybody who's poor and can't pay, and put them into Medicaid. So it takes that small bit of the market, and then that's exactly what we see with mental health in the UK already. We'll see more of that. So if you're young, fit, healthy, you need some non-urgent surgery, yeah, fine, it'll be okay. If you're old, if you've got multiple chronic diseases, too bad.
Anita, the NHS budget in England loans about 120 billion quid a year.
Yeah.
People from abroad will want to get a slice of that if they can, won't they?
Well, I think as Martin has suggested, the issue at the moment in the UK is with funding hugely constrained. Are there the private returns there in the short term? I guess the bigger picture around all the trade deals are, will our economy grow? Because we spend 120 billion, it's, you know, it's a share of GDP that's, you know, around the 7% in terms of the public funding. Obviously, many people did listen to the promise of 350 million a week extra for the NHS, and the NHS certainly featured really prominently in the Brexit debate. One of the biggest risks around Brexit to the sustainability of the NHS is economic growth. And so that's the wider picture for that. The other thing, I guess, which is an issue around all of this is the importance of the pharmaceutical industry. Moving forward, we obviously need to make sure that we are competitive in industries that are high added value. Life sciences is one of those. We're part of the European Medicines Agency. I think one of the things that people didn't understand perhaps so well pre-Brexit is that when we're involved in manufacturing, people don't manufacture a whole product in one country. Yeah, so stages of production move all around Europe, all around the globe, and a lot of the trade rules facilitate that. If those trade rules are not in place and recognition is not in place, it will be very hard to maintain a manufacturing base and a research base in pharmaceuticals here. So that, I think, is one of the real issues around Brexit. And then, of course, you know, we're almost certainly going to lose the European Medicines Agency, which is based here, with another set of really high-quality jobs that are here. So I guess those are some of the big risks.
Rachel, if the NHS became opened up to further competition, would that help or hinder the NHS?
Well, this is a huge debate in general in the NHS, and of course the government's argument would be the injection of competition is a good thing, it drives up standards, we're familiar with that argument. What I see is the exact opposite. I see the creaming that you've just talked about, Martin, already happening. So private companies take away the cataract operations, the hip and knee operations, they're low risk, you can churn them through at volume. Anything that's difficult or risky is left for us, the NHS employees, to deal with. And incidentally, we also deal with the fallout and the problems and catastrophes that sometimes occur in those low risk, privately run operations conducted at bulk for profit. In other words, already the NHS overall is suffering from the injection of competition. Every time Virgin takes away a low-risk aspect of NHS activity, they are creaming off profit. They are conducting their activities not for the best interests of patients, which is what I do and any NHS employee does. They're doing it for the benefit of their shareholders. We only have one pot of taxpayers' money in the NHS, and the more that gets creamed off by private companies, the less that is left available for other patients. And it's always the patients with the quietest voice, the ones that are not able to be heard, who suffer most as a result of it. It's the elderly, it's people with mental health problems in particular. There's no parity, that's all warm words, and I can't bear that as a doctor.
One very practical, pressing issue involving the NHS and Brexit, Martin, of course, is the future of the reciprocal healthcare arrangements that we have.
Sure.
And I don't know, it's many millions of people here who go on their holidays in Europe have the European health insurance card, which is a great thing, helps many people in difficult circumstances. What are we looking at the moment?
Yeah, well, you're absolutely right. And as you say, and not just people going on holiday, there are people who are working in the UK from other parts of the EU who use this. One of the main reasons they use it is that they often go back to their own countries where their family are when they have children, to deliver the children. So there's a lot of, it's really very complicated, hundreds of thousands of pensioners. Now, at a time when the NHS is really struggling, and I think we should also remember it's struggling not just in terms of the performance measures. Let's just remember that death rates, which were declining markedly up until 2011, have now, we can debate whether they've stagnated or reversed among the over 75s, but this country is unique in Europe in having had that stagnation or rise in death rates among the very old. So there's a real problem here at the minute. Older people are suffering in this country in a way that, and the Institute of Actuaries showed it, we've showed it, and I think we've actually missed that bit. So at a time that the NHS is struggling, the idea that you would then get several 100,000 British pensioners living in France and Spain and elsewhere and take away their health care so they can no longer afford to live there. There'll be a move back. Their houses will be worth nothing, the houses they've bought there. They will be coming back to the UK at a time when the 90,000 people from the rest of the UK providing social care here are being made to feel less and less welcome. And we've already seen a 92% fall in applications from nurses from the rest of the UK to come here. So we're getting rid of all the people who care for them and sending them back to the rest of the EU. We're bringing in several 100,000 people, many of whom are either now highly dependent or will be. And we expect the NHS to cope with that. I mean, at a time whenever the Office of Budget Responsibility tells us we'll have a massive hit. And then we have the practical issues. Because did anybody vote to leave the European Atomic Agency? Do you realize that we import virtually all of our radioisotopes from the Netherlands? We will not be able to do that. So if you need a diagnosis requiring radioisotope, if you require cancer therapy after B-Day, after Brexit Day, forget it, unless somebody works very, very hard to sort something out. And given that, as we already know, when David Davis appeared before the exiting the EU committee, he was asked about the European health insurance card, and it was as if it was the first time anybody had mentioned it. It was a complete surprise to him. And yet, in contrast, at the famous Brexit dinner in Downing Street, the issue that led to Juncker's puzzlement with Theresa May's apparent lack of understanding of anything to do with the European treaties was the health issues, the mobility of people. He raised the issue of health and then got this utterly bizarre, meaningless response. And that was when he said, I'm skeptical, because he became clear to him, these people actually don't know what they're talking about.
Rachel, Martin mentioned the NHS's reliance in the health and social care system, generally reliance on European workers. You work as an NHS doctor in Oxford. How reliant is the NHS that you see and you work in on European staff? And from what you picked up, what are those European staff feeling post the vote last year?
So last year, on the day of the Brexit news, I rocked up in my hospital where, on my ward, the majority of the staff were from continental Europe. The minority were British-born nurses. 1 in 10 doctors we know are from the EU as well. And on that morning, I met my consultant, a German who's been working here for 3 years. And she burst into tears on the spot because she felt so alienated and let down by the prospect that really had never occurred to her, that she inhabited a country where she had always felt she was welcomed and valued, that had essentially, she felt, stuck two fingers up to her. And that is a feeling that is replicated among so many of the doctors and nurses that I work with. People say, don't worry, there'll be some kind of arrangement so that EU doctors and nurses can stay after Brexit. It won't be a problem. Well, first of all, we have no idea if that's true, but secondly, this sense of feeling unwanted, undervalued is absolutely dreadful for doctors and nurses, without whom we could not survive as an NHS. Understaffing is so severe at the moment in the health service. It's the single biggest problem that imperils patients. We all have been screaming from the front line about the dangers of understaffing. That's now, that's even before Brexit. And to give you a simple example of how real and vivid and inhumane those statistics are, I now work in a specialist palliative care unit in Oxford. So my patients, and we have 20 beds, are patients coming in from the community with the most horrendous and dreadful and debilitating symptoms arising from usually terminal cancer, but other diseases as well. We have 20 beds. When we don't have enough nurses in our unit, we close beds, and this happens far too frequently, at least once a week. So we go down to 18 or 16 beds, and that's not a problem locally or with our hospital. It's a problem that's replicated in every hospital, every ward, up and down the length of the UK. And when that happens, the human cost of that is that there are 4 patients now out there in Oxfordshire dying of cancer with desperately complex symptoms that need to be managed by a palliative care specialist like me. And I can't do my job of looking after them because the beds have been closed, because there aren't the nurses to staff them. That's now, even before Brexit. And all of us who work on the front line are petrified about this situation worsening once Brexit goes through, because the inhumanity currently is so utterly dreadful.
Anita, is Rachel telling us it as it really is, or she may be exaggerating a little bit? Or what are the facts?
So the numbers absolutely bear out what Rachel has said. And I've spent the last year working with a committee that was set up by the House of Lords to look at the future sustainability of the NHS. And they had a look at the funding model. You know, people have said, isn't it the funding model that is actually unsustainable? No, it is not the funding model. They're very clear. The biggest internal risk to the NHS is these workforce issues. And we are already 40,000 nurses short in the NHS. Without Brexit, we actually have no expectation in the system at the moment of having enough nurses even by 2020 on current plans. And obviously there's a big risk that Brexit adds to that. And the impact, I think, is both financial in terms of having to spend on agency staff, but also it means that a lot of the things that people want to do to improve care are all about how a team on a ward or where it is works together to think about how do we deliver care at the moment, how can we make that better? How can you be a team where every week 10-20% of that team is a different person? Yeah? That's not a team anywhere that I have worked. And often what that means as well is if you don't know the people you're working with, you practice very conservatively and you end up needing more staff. And for, most of our hospitals now are full of elderly, frail people. Dementia is a big part of their care. Huge instability in who's caring for you is deeply stressful if you have dementia. It exacerbates those issues. So we did some work looking at how important continuity of care from your GP is. And it's, the more continuity of care, the less likely you are to be admitted into hospital. It's very clear that stability of the workforce is really important for the ability of the NHS to continue to improve and to deliver quality. And in social care, something like 30% of the workforce leaves every year. The churn is phenomenal. And so we have a real issue with this. But it is quite likely, I would have thought, obviously, that for doctors, through some kind of high-skilled or points-based system, we will address this. But what will happen at lower skills? We don't just need those very high skills. In social care, it is people with low-level skills, but our system would collapse at the moment without that workforce. I guess the other thing that we need to understand as well is it's not just securing the future for the people who are here at the moment. We need to train our fair share of workers internationally, and we have not done that for a long time, and that is wrong. And so we need to train more people in this country. But what we don't want to be is a closed healthcare system. One of the ways in which innovation and ideas happen in healthcare is by people moving around the globe, sharing best practice. So good global citizen means we share our own share, but putting up the barriers and saying we're just going to have UK people working in the NHS, we're not going to be part of that global community that is developing ideas, would be really, really wrong. So it needs to be a system not just that guarantees the existing workforce's future in the NHS, but does allow us to be part of that global flow of workforce if we're to be part of the development of ideas. And that's really important for research as well. And research, again, is something that's been a lifeblood of our system and really important economically and to our university sector, which is a huge part of our success as a nation.
So with money problems, staffing problems, Brexit coming down the line, the ageing population, the growing population, the complexity of healthcare, the understandable, I think, patient and doctor demand to be able to access the latest developments in technology, medical equipment and drugs in particular. Is the NHS panel, do you think, a sustainable system of healthcare? Martin.
Yeah, it's going back to what Nick Clegg said about the way in which our national discourse is dominated by people in the media. The fact that you're even asking the question is really quite interesting. Many of you will have smartphones in your pocket, I guess, and if you look at our expenditure on smartphones over the last 2 decades, it's gone from 0% of GDP up to quite a significant amount. And are we having a debate about, can we afford to have smartphones in the United Kingdom? Well, no, we're not. But the point about it is that you buy your own smartphones. The difference with healthcare is that we're asking different people to move things around. We're asking for redistribution of resources. We're asking those of us who are relatively well off and relatively healthy to pay for people who are poor and sick. And that's the issue. It's not about can we afford it. Once upon a time, this country was the 5th largest economy in the world. Now, obviously, since last June, it's now the 6th and the 7th, and it's working its way down the system. But we can still afford a lot of things. We can afford, for example, nuclear missiles, even if they use Windows XP in their system. That's another issue we can look at, and even if the missiles go in the wrong direction. But, we can afford an awful lot of things. This is not about whether we can afford it, because as the House of Lords report showed, and as actually anybody in health policy knows, this is the cheapest system to run. Anything else we do will be more expensive for the country as a whole. The only issue is who pays. And if we look at the push to repeal the Affordable Care Act in the US, it's nothing to do with healthcare. This is about tax cuts for billionaires. And in the same way, even asking the question, is the NHS sustainable, is actually a pretty dumb question. Because if it's not sustainable, many of you are looking at the... sorry, Denis, but many of you looking at the audience there, many of you are as old as me or even a little bit older. Well, if we're willing to let you all die, if you're willing to let everybody else die, fine, it's not sustainable. But if you actually think that people should be helped whenever they become ill, well, then it's the best possible system. One of the things I would say is there are definitely economies, efficiencies that could be brought about. For example, we could repeal the 2012 Health and Social Care Act, which introduced a huge amount of bureaucracy. That would be a good start, but otherwise it actually works pretty well, and it has done historically well. It's a cheap system, and it's not unique. It's the one that's used in the Scandinavian countries, in Spain, in Italy, in Portugal, many other countries in the world who have actively emulated us. The Lorenzo Plan in Italy, the reforms, the Abril reforms in Spain, looked to the UK because they looked across the world, and the NHS was the cheapest, the most efficient, and in countries where there were not powerful vested interests pushing another way, that's the route that they went.
Rachel Clarke.
So, in answer to your very silly question, I think there's a very simple answer, that the parlour state of the NHS today, and there's no denying that it's in pretty dire straits, is not a matter of economic necessity, as the government loves to pretend. It is a political choice. It is a choice to shrink the size of the state. And given that it's a political choice, it can be unchosen. And who are the people who unchoose it? They're us, the electorate. And my reason for having faith in the NHS that I love to work in, and it's my honour and privilege to do so, is that I don't believe there is any other institution in Britain that better represents the compassion, kindness, openness, tolerance, diversity, and mutual respect of the British population for each other. And I don't believe that when it comes to the crunch, the British public are going to allow any government to abolish our NHS. So I have faith for the future.
Anita, you, as you mentioned, you spent the last year helping the House of Lords with their inquiry into the future of the NHS. Tell us.
So the OECD, who've looked at this across all health systems, have concluded that a tax-funded system has some huge advantages. It is systematically cheaper. We spend less on administration than most other systems. It is fair. We have less of a problem than many other systems in terms of costs being a barrier to getting good quality care. The other thing, I guess, being an economist to say as well is that, so people often talk about the US. I always think actually perhaps the better place to look at for alternatives is in mainland Europe. And one of the alternatives people talk about is social insurance. Social insurance actually does have one big problem. It's paid for almost exclusively by people in work of working age, and it is essentially a tax on employment. And in countries like France and Germany that have those systems, they are very worried about the sustainability of that with the ageing population and with all the pressures that we all know about on the living standards of people of working age, particularly younger people. So and what the OECD conclude is that basically we should spend, I think, all of us less time angsting about whether you have a tax-funded or a social insurance system, much more time worrying about how much we spend on it and whether we use that money well. I would say two things in addition to that I do think we need to really think about in public debate, though. One is the NHS is under pressure, but the model is secure. Yeah. The social care system is broadly on its knees. Yeah. And if we need to do anything of urgency, and if there's any money around in the next few years, we need to put our social care system back on a sustainable basis. This is used by some of the most vulnerable people in our society. 400,000 fewer people getting care over the last 6 years. We don't hear from them because they're at home in silent misery. They can't get out. That's the implication. Not washed, not fed, seeing no one. We have an epidemic of loneliness that is very related to that. The other thing is obviously it would be pretty daft as well to fund our NHS by cutting some of the other public services that drive our need for healthcare. So we do need to think, you know, the NHS is important, but in the end it's a means to an end, you know, and the goal is health. And doing things that make people sicker and then putting money into a system that props them up when they're sick is not really sustainable. So we do have to have, you know, there is no way round. If we want a healthy population, people in the end of their life treated with dignity, then we will have to pay for it, and all of us will have to pay for it, not someone else. Yeah.
Right, let's have some questions. We've got about 13 minutes for questions. So could people come up to the front? I'm going to take a couple from each side to start with, and we're going to take a first group of 4 and see how we get on with them. Madam, you were first.
Madam.
Sorry, it's the lights. Sir. The lights are very bright.
You know, I'm very free and open, but thank you for that. That's, can I get that on the NHS today?
I'll give you my glasses.
Firstly, my name's Peter Cook. I'm not a madam, but never mind. Yeah. I wanted to ask a controversial question, and it relates to what Nick Clegg said previously about uniting and sort of coming together. I love the NHS. I fully support that. But the Tories and the media are all about divide and conquer, and I get sort of somewhat tired of, we seem to have a begging society now. The scientists saying science matters, the NHS saying the NHS matters, everyone says, the Toyotas say that they matter. And therefore, could we pull together, the overriding issue is Brexit. Yeah. If we fix Brexit, we fix the NHS and all the other stuff. So that's my question, can we pull together?
Okay. Thank you, Peter.
I worked in the States in the American healthcare system, and some of the things I saw were really horrendous. I worked in the second busiest ED in the United States, in Miami, Florida, and sometimes people were on a backboard, strapped to a backboard for over 8 hours. Do we want to go there? And that's what we need to think about.
Thank you. Sir.
Hi. I'm a bit of an oddity in that I'm a company director and relatively well off and would like to pay more tax and have been frustrated. And have been frustrated by a number of things. I used to employ 365 people and had to give P60s to 355 of them because of the ludicrous pensions system that was imposed by the government that is unworkable for seasonal employers. Now that's taken away by my back-of-the-envelope calculation, £50,000 per year that we used to give to the NHS. Now, it's really irritating being someone with some cash and a business, and I can't give it away. I mean, quite literally. I mean, there's a sense in which there seems to be lots of income streams that have been hobbled by the government or not taken up. Now, as an employer with seasonal employers now are on self-employed basis, why isn't there a move for people like me to have to pay something? You know, just even if it's you employ 350 people, so we want £100 a year for each person, anything, take my money. But, you know, it seems to me very frustrating. And I hope I'm not alone in being in my financial position and wanting, I don't want to give it to this government particularly, but some government that actually represents the people. And, you know, how do we get to that position where the money's taken from people like me, frankly?
Thank you very much. And one more.
Okay, I'm fully committed to an NHS in the public sector and free at the point of care, so I welcome the panel's commitment to that. I'd like to ask, though, if the panel think often technology is seen as something that's bringing in more costs, but where do they see efficiency savings, such as through automation, which could be a really positive development? So I'd like to hear if you've got anything to say on that. Thanks.
Okay. Thank you. So that's 4 questions. I'm going to ask the panel to answer, not all 3 to answer all 4 questions, just whichever question you're most comfortable with. Martin McKee, please.
Yeah, okay, sure. Brexit, if we reverse Brexit, it wouldn't solve the problems, but if we don't reverse it, it's going to make them an awful lot worse. I think the point that was raised about small and medium enterprises is essential. Now, the healthcare system in other parts of Europe actually works actively to promote that. So by breaking up contracts, so in Brandenburg in Germany, for example, the contracts are designed so that they don't get given to the big multinational corporations that dominate contracts in the UK. In northern Italy, the same. So they're designed to actually work with local suppliers, and because those local suppliers then put money back into the economy, they employ the local accountants, the local lawyers, and so on, and the money is not all shipped off to the Virgin Islands or somewhere like that. So the healthcare system can contribute, but the government has to contribute by not doing everything to support the big multinationals, the big private equity companies, but to actually work to support the individual, the local people who support the local economy, and by giving jobs to people locally, make them more healthy and reduce the workload on the healthcare system. The scope for automation, there's a lot more that can be done in terms of the flow of patients, because in many areas of medicine, about 80% of people, breast lumps, rectal bleeding, blood in the urine, things like that, well, about 80% of people will at least follow the same pathway for the first part of it. They may go somewhere else afterwards. And you can streamline the system. We've done books on hospitals. The Netherlands does really, really well on this, actually. But you can only do that if you've got capacity. And if you're running your healthcare system at 98% capacity or 102% capacity, as in the UK, you simply cannot do it. And you need to invest, and you need to invest particularly in the facilities. And to get a system like the Private Finance Initiative, leave aside the money. The point is that you're building a hospital that was designed 10 years before it opened, and then cannot be changed for the next 25 years. The walls are concrete, they're solid, you can't move them around, you can't even put in new electrical sockets. That is completely ludicrous at a time when technological change is moving so quickly. There are many good examples in Germany, Rhone Clinicum, in the Netherlands, in Finland, that we've looked at working with Arup and with the European Investment Bank, where you can build in flexibility into the system. As to the US, simply look at the death rate from conditions amenable to healthcare. There'll be a paper coming out in the Lancet next Thursday that will look at this. Have a look at that, and you will see that the US has made virtually no progress in reducing those rates, which are among the highest in the industrialized world over the last number of years. The US health system is a disaster.
Rachel.
So I'd like to touch on the question the gentleman asked about the need for us to come together and not all be pitted one against the other when it comes to health and the NHS. And I think a really important point to make there is one of the reasons we have these groups shouting and screaming sort of at odds with one another is precisely because this government's tactic when it comes to discussing NHS performance, statistics, data, evidence, facts, is essentially to deny them, to try and spin them away. So instead of actually being honest with all of us, you, patients, the electorate, me, someone who works in the NHS, and instead of admitting that there's a problem, every time the latest statistics come out, the winter crisis statistics from this January, for instance, the terrible statistics on lack of nurses and doctors and poor morale, they try and spin them away. And the problem with that approach is it means you now have set everybody who works within the NHS against the government. We're all screaming one thing, there are problems here. The government press officers are saying, no, everything's fine, it's absolutely wonderful. And of course, the truth is, it isn't fine, it isn't wonderful, and if we want a world-class health service, we have to pay for it. We have to provide it with world-class funding. And the question that we really should all be asking, and this would be a way to bring everybody together in an honest and upfront debate, would be this. It would be to say, do we want to pay for a world-class health service, or do we want to ration and cut the healthcare that we are willing to pay for to fit the budget we find acceptable? It's either or, you can't have both. And For as long as the government denies that, we will be at odds with each other. We need to have that honest debate, and there is no shortcut to that.
Anita, briefly.
So I guess one of the things that we need to think about as well, though, is that the NHS scores phenomenally highly in terms of public support, and it's pretty clear everybody here reflects that view, and it is a really strong system. But at the same time, it's also clear that the service needs to change, and change quite significantly, to adapt to how our needs for care is changing. One of the things that is being talked about, I'm really pleased about, in this general election campaign is the state of mental health services and mental health in our country. And I was telling Denis just before we came down, I'd been looking at some of the mortality statistics, and still can't get over the fact that for children aged 5 to 19, the leading cause of death for now is suicide and self-harm. It's just overtaken road traffic accidents. So very clearly, which as a society is just a scandalous place to be. So the NHS clearly has a really important role to play in making sure that children and young people who have mental health problems get access to care really fast. And we know at the moment that isn't in place. Yeah? We know at the moment that isn't in place. But also, and when we worry about waiting times in A&E, and they are important, we all need to think about the fact that that is the bit that we see. But actually, these things like what's happening to our children and young people, they really matter as well, and they're the invisible bit. But actually, it's not just the NHS, and so this is the point about not pitting services against each other. You know, the situation that leads to a society in which that is the leading cause of death for children and young people cannot be fixed solely by the NHS. And we, you know, if Brexit is to happen, if one of the few opportunities that might be that we take a long, cold, hard look at ourselves and think, what do we want to be in the next decade? Surely we must be a society where that is not the case. And we do need to look beyond the health service at all the services that lead to that scandalous situation.
I regret that the clock above our heads says 10:29:45, so we are out of time. I'm sorry for all the people who want to ask questions, and the panelists, I'm sure, would share that disappointment. Can I just thank you all for coming and listening and giving up your time this morning to come to listen to our panel, and could I ask you to join me in thanking, in the normal way, our terrific panel.